program on Does Treatment Work will be presented by Dr. Carl Christensen. Dr. Christensen is a clinical associate professor at the Wayne State University School of Medicine and has a private practice in Ann Arbor, specializing in treating chronic pain and addiction. He is certified in addiction medicine and is a fellow of the American Society of Addiction Medicine. He is the past president of the Michigan Society of Addiction Medicine and the current medical director of the Michigan Health Professional Recovery Program, the James Wardell Women's Recovery Center, the Tolan Medical Research Clinic in the Wayne State Department of Psychiatry, and Don Farm. Please help me in welcoming Carl Christensen.
Thank you. You know, you're going to see a lot of quick blurbs on different research articles and different scientific journals and stuff. If you're interested, if you send me an email to that email address, it's also on your handout. I will send you a Dropbox link that has all the papers in it. Just give me a few days to get it organized, and that email address will be at the end of this talk too, and it's also on your handout. So I want to talk about my disclaimers. I spend a lot of time with medication-assisted therapy. I'm a methadone provider at the Wayne State Psychiatry Clinic. I'm a buprenorphine provider at the clinic and in my private practice. I'm a Naltrexone provider for Vivitrol, and I also work at Don Farm as the medical director, which is an abstinence-based treatment program. So I like to describe myself as being fair-minded and working with all different kinds of treatment. And other people describe me as being promiscuous, so I'll let you make your own choice at the end of the talk tonight. And I need to warn you, this is considered by some people not to be a real uplifting talk. We've been giving different versions of this talk for Don Farm for like 10, 15 years. And we finally started getting audience feedback that I would take home and look at, and this was one of the comments I got. And I thought, well, you know, that's not right. I'm going to rewrite the talk and spruce it up and put more treatment in. And this was the response I got when I changed the talk. So again, I'll let you make the decision about, you know, how enjoyable this is. So the first thing is you have to decide, if you're looking to treat addiction, you have to decide what you're looking for. And there's really three levels, and probably the most basic level is harm reduction. And the obvious example of that would be a needle exchange program where you're not even stopping the patients from injecting heroin, but you're providing them with clean needles to decrease HIV and hepatitis transmission. Or there's abstinence, and that means abstaining from a drug, and it can either be the drug that you're worried about, like heroin or fentanyl, or it can be all mood-altering medications, and that can be provided in different treatment centers. And then finally, there's recovery, which is kind of the most nebulous term that you always have, and people always argued for years, what is recovery? And finally, a bunch of our experts got together and gave us a definition. And this was at the Betty Ford Center. This is like 10 years ago. And they got together and they decided to tell us what recovery is. And they say that recovery is sobriety, which means abstinence from mood-altering medications, all medications, not just the one that you believe you're addicted to, and I'll come back to that. Health, which includes mental health, physical health, and what they called citizenship, which means to give back. And I think most of us would refer to citizenship as spirituality. I'm going to talk a little bit about spirituality later on when we talk about different types of treatment. And also, recovery means that you have an improved quality of life, and I'm going to talk about different arguments about whether or not medication improves your quality of life or whether or not it has to be an abstinence-based program. And the other thing is, where do we get these decisions from? If I say, this medication works or this medication doesn't work, where do we get the information from? And this is the levels of evidence. This is religion if you work, you know, in the clinical field, anywhere from level 1 to level 3, and I call level 4 just, you know, I've made a decision already and now I look up articles to support me. But level 1 is the gold standard. That is God. That is a randomized, blinded, experimental trial where I don't know what I'm giving you, you don't know what you're getting, and there's a control group, and then you run the study and see what happens afterwards. And we'll talk about a few of those that are done, but there's not many of them. In fact, most of them are level 2, which means 2A means a flawed randomized trial. So for example, I can randomize you to a drug out of 2 different drugs, but if one drug makes your hair fall out and the other drug makes you throw up, there's no way that you're not going to know which one you're getting. So some trials cannot be successfully randomized, and we'll talk about that. Or it's the most common one, which is level 2B, and what that means in English is you didn't do an experiment at all. You went to a hospital, you found a bunch of hospital charts, you look at people that smoked, and then you look to see what happened to them in terms of lung cancer, or breast cancer, or something else. And most of the studies I'm going to talk about are not experimental, they're observational, which means a level 2 study. And we also have to talk about ethics of treatment. If we're going to offer treatment to a patient or go over treatment options with a patient, what guides us? What tells us what to say to a patient? And probably the most important ethical principle that we work with is non-maleficence, which means first do no harm. So if you are somebody, for example, and I'll talk about this, who is asking to go on methadone, but you're drinking a 1/5 of alcohol every day, and you've got a prescription for Xanax, that's a potential for death. And I would not offer that to you. So the most important thing is don't offer something that's dangerous to a patient. And then the other 2 are beneficence, which means to do the right thing for the patient, and that means an overall assessment is what is best for the patient, and sometimes that drifts off into telling the patient what they should do, and that's called paternalism, and that's something we try and stay away from. And then finally, autonomy. Autonomy means that you make the choice of what you want to do, but it implies that I have given you all the information you need. So autonomy means informed consent. And I think one thing that we see in addiction treatment is that everybody has their belief about what works, and if you go to a certain treatment center or a certain doctor's office, you're going to hear that this is what works and I want you to do this, and nothing else works. And that's a failing that we have in addiction medicine treatment. And then another one that comes in is justice. Justice doesn't mean getting you what you deserve. Justice means how do we divvy up medical resources? As you know, there's only so much money to go around for addiction treatment. It's probably going to wind up shrinking. So all the different treatment providers are fighting for their share of the pie, and that's where a lot of the argument comes from. So we're not able to go over a long talk tonight about the brain and everything in addiction, but addiction is not withdrawal. Withdrawal is what 99.9% of doctors think is addiction, and about 98% of the patients I see, and they tell me, if only I could get over this withdrawal from the Norco or the heroin or the alcohol or the Xanax, I would be okay. And that's not it, because withdrawal, except for things like benzos, is gone very, very quickly, and then what you're left with is what we call the 4 C's. And that means craving, which means all I can think about is I want my drug. So I'm talking to you right now, but I'm thinking about the party store down the street on Gulfside and how they're open until 10 o'clock, and I need to get there before 10 o'clock. I have to use it just to feel normal. That's compulsive use. And I'm not talking about an eye-opener. If I don't get my 3 martinis a night, I turn into some kind of raving maniac. And speaking of 3 martinis, I lose control, which means that I might have 12 martinis instead, go out driving and get arrested. But despite consequences of loss of my job, my family, my friends, my home, I continue to use no matter what. And then I like to throw in a 5th C, which is chronicity. We don't diagnose addiction based on one event. It has to be repeated behavior, and it typically gets worse over time. And I just want to address these folks and then move on very quickly. If you go on the internet, and I rewrite this talk every year, so I have to go through all this nonsense, you'll see all this stuff over the internet about how addiction is not a disease, it is a life choice, it is a life phase, it is a moral wrongdoing, and oh, by the way, buy my book, okay? If you read anybody online who talks about addiction and the bottom line is buy my book, just close the window and move on. So this is one guy from, I think he's from Harvard, and he has decided that addiction is not a disease, it is a brain phase, and oh, by the way, buy his book, okay? And I like to think these folks as mosquitoes, okay? I love going out in Michigan in the summer, but one bad thing about Michigan in the summer is mosquitoes, and you just swat them away and go on with your work. And if you are in this room, either you have experienced a problem with alcohol or drugs, or you deal with somebody who has, and you've been touched by this. and you know that this is not a life phase. This is deadly serious, and because of the opioid epidemic, it's getting worse, not better. So we're going to first talk about opioid dependence, which is our main focus tonight. And we're going to talk both about prescription pill addiction and illicit drug addiction, especially heroin. And as you've probably heard, the heroin out on the street now is also very often contaminated with fentanyl. And we're going to talk about two different kinds of drugs, agonists and antagonists. Agonists are drugs that are similar to the drug problem you're trying to treat, and antagonists block the drug that you're trying to get rid of or treat. And for agonists, there are only two that are really out there in the market, and that's going to be methadone and buprenorphine. And for antagonists, there's only one, and that's naltrexone. And naltrexone comes in a pill or a shot, and we'll talk about those. We are not talking about naloxone, which is Narcan. Narcan is not for the treatment of addiction, it's for the rescue from an overdose, and we'll come back to that. So let's start off with methadone. Methadone has a terrible reputation, and a lot of it is entirely deserved. I've been working in a methadone clinic for 8 years, and all kinds of terrible things happen in a methadone clinic, but it's been shown over and over again that there is drastic or major harm reduction when someone goes to a methadone clinic. There's a decrease in dying, IV drug use, crime, HIV, hepatitis C, relapsing on drug use, and you gain your health, you typically get your job back, and you get your life back. Okay, and there's a lot of people will argue about this, but if you're talking about harm reduction, methadone is one of the most powerful treatments that we have out there. Most people who go to a methadone clinic are not in recovery. Most of them are not even abstinent. But a large number of them will stop using heroin or prescription pills, which is what often we are dealing with. The problem with methadone is it builds up very slowly in your body. That's why it works. Once you get to a stable methadone dose, you don't have to worry about it going up and down. But if you give somebody too much methadone too soon, you can kill them. And I'm going to show you a study that shows that one of the most dangerous times in an addict's life is the first 2 weeks they go to a methadone clinic. If they take too much too soon, it can be lethal. This is the same dose of methadone. Is this working? Same dose of methadone given over a period of 3 days. That same dose doubles in your blood and doesn't peak until you're about 10 days out. So only someone who's experienced with methadone should prescribe methadone, even in a clinic, and you have to have guidelines and you have to be very careful. It's a dangerous time in someone who transitions off heroin. So this is a study done by Dr. Ball in 1988. This was the peak of the HIV epidemic, or close to the peak. And what they were concerned about was how do we decrease the HIV transmission, which was largely due at that time to IV drug use. And this is a combination of 6 different clinics, and what they found was over a period of 4 years, there was a 70% reduction in IV drug use. That is astounding in addiction treatment. There's just no way around it. However, we talk about the brain disease of addiction, how people with addiction are impulsive, they're compulsive, they have poor judgment, all these things you've probably heard about or experienced firsthand yourself. And these same people who were doing well decided that it was time to move on, they were cured, and they need to leave the methadone clinic. And here's what happened. When they left, about 30% were using, and a year later, 80% were using. An 80% relapse rate. So methadone, I'm going to say this over and over again, and this sounds stupid to say it, but methadone works as long as you take methadone. Okay? And it has about a 20 to 50% success rate in most clinics, and that talks about abstinence from major illicit drugs. So this is more recent studies. This is from 2009, and this study just looks on the left-hand side of how likely you are to die in treatment or out of treatment. And this is like per 1,000 patient years or something. But look at these numbers. Going from in treatment to out of treatment, this is for methadone and buprenorphine, the mortality rate goes from 2 to 6. It triples, okay? So there is really no question that if somebody is in drug treatment, buprenorphine or methadone, and they leave, they are at increased risk of death. and things are probably worse now because this study was done in 2009, and that was before fentanyl and carfentanil and everything else came along. Now, this is a weird study, but what it shows is, what are your chances of dying in the first 2 weeks of treatment, and what are your chances of dying in your first 2 weeks out of treatment compared to being in treatment? And this study showed that your chance of dying when you leave treatment went up tenfold. Okay, that's a big number, okay? That's 1,000%. But even weirder, your major chance of dying in a methadone clinic was the first 2 weeks you were there. Why? Because a lot of docs don't know how to prescribe methadone. They give you what you need to get you out of withdrawal on day 1 or day 2, and then a week later when it kicks in, if you're drinking or taking Xanax, it can be fatal. So this is the most dangerous time there is. And that does not apply to buprenorphine treatment, only to methadone treatment. So going out of treatment is bad, but one really dangerous time is your first 2 weeks of methadone treatment. This is the latest study. This is 123,000 patients treated with buprenorphine and methadone, and look at the mortality in and out of treatment. And over on the left is methadone, over on the right is buprenorphine. Methadone, the mortality rate, again, this is per 1,000 patient years, the mortality rate goes from 3 to 13 for overdose deaths when you leave treatment. For buprenorphine, it goes from 1 to 5. Those are both like a 5-fold increase. And I told you before, the last study showed a 10-fold increase, whatever, but there is a major, major increase in dying when you leave treatment. Okay, so take-home points, mortality goes down when you go into treatment. And they say it goes down overall at least 30%. And now with the fentanyl around, it may go down even more. I have been at our methadone clinic, I think it's 8 years out of the past 9 years or something like that. We have never had a patient die while they were being treated in our clinic. Never. We've had a lot of patients die when they leave our clinic, both being discharged for not going by the rules or discharged because they wanted to leave, but we've never had anyone die while they're under our treatment. When you leave treatment, your chance of dying goes up. And especially your first 2 weeks in methadone treatment are very dangerous, and then your first 2 weeks out of treatment for buprenorphine or methadone are also dangerous. Now, a lot of people talk about, in fact, we're going to talk about it later on, the new administration, talking about treating addiction with medications is just trading one opioid for another. I'm going to show you that quote tonight. And people argue that the quality of life with methadone is not good, and that is very potentially true. I know people who have very good recovery in our methadone clinic. They run groups, they run meetings, they're doing very well. They've been completely abstinent for years. And I know people who are just there for the 12 weeks that they're allowed to stay, and then they move on to a different clinic. So quality of life with methadone can be all over the place. And these are just different studies saying yes and no on both sides. Now, one thing I am not talking about is methadone pills. Methadone pills are deadly. Methadone should never be prescribed by anybody unless they are very experienced with methadone. Methadone prescriptions are 3% of the opioid prescriptions in the U.S. and 30% of the deaths. And this is a graph of methadone overdose, methadone deaths, and admissions to treatment for opioids. It's like a straight line, they're parallel lines. So it's very easy to get your hands on methadone tablets, and it's very easy to take too many. It sneaks up on you, and you die from respiratory depression. The FDA contributed to this. The starting dose of methadone should be 5 to 15 milligrams, and they put on the bottle the starting dose was 80 milligrams. Hundreds of people died the first couple of weeks. And they decided, oops, let's change the label. So, all right. So let's move on to buprenorphine. That's our other agonist. Buprenorphine is what's called a partial agonist, and what that means in English is that it grabs your brain very tightly, but it doesn't cause the same amount of effect. And the effects we talk about with opioids are pain relief, withdrawal relief, and respiratory depression, meaning you stop breathing. And buprenorphine will grab onto your brain tightly but not cause the same amount as it would with morphine or heroin or methadone. There are 4,000 to 5,000 deaths per year with methadone, and there are probably less than 100 with buprenorphine. Even with the increased amount of buprenorphine out there, the number of buprenorphine deaths is very, very small. And a lot of those deaths occurred when the brand name Suboxone was a bright orange pill that looked like candy, and unfortunately kids would find it and take it, and they would overdose. And the relative risk of dying is anywhere between 4 and 100 if you compare methadone to buprenorphine. It's very dramatic. So this is what you're going to hear this all the time if you talk about buprenorphine or methadone. This is a full agonist, partial agonist, and antagonist. So this is how much effect you get, say like pain relief. This is how high your dose is, and this is the curve that you see. As you go higher on the dose, you get more pain relief, you get more relief of withdrawal, and you get more relief of breathing. You stop breathing, okay? So methadone, morphine, heroin, fentanyl, they all give you the most bang for the buck. Antagonists like naloxone and naltrexone, no matter how much you take, you're not going to stop breathing. It's actually going to wake you up if you have stopped. And in between the antagonist and methadone is the partial agonist, which is buprenorphine. And we normally don't talk about brand names during a talk like this, but you have to because the FDA has approved different brand names for different indications, and sublingual, under your tongue, buprenorphine is approved for addiction treatment. And the different brand names that you're going to see for this are what was called Subutex, which is straight buprenorphine, that was taken off the market and now is back on the market. And then you have combinations of buprenorphine and naloxone. Naloxone is one of the antagonists. They mix it in there, so I'm sure a lot of you have done this. It's Saturday night, you're sitting around, you've got some buprenorphine product, and you just melt it up and inject it, right? Everyone does that. If you do that when you have one of these drugs, you will go into withdrawal. If you just put it under your tongue like you're supposed to, you will not. So this is mixed in as a deterrent, and otherwise it's not active. We don't worry about it. But these are all sublingual, buprenorphine and naloxone, and the brand names are Bunavail, Suboxone, and Zubsolv. And the patient starting these medications has to be in withdrawal when they start, otherwise these medications, which are very potent, will put you into withdrawal. These are the brand names that are approved for pain, which we're not talking about tonight. There's a shot called Buprenex, a patch called Butrans, and a film that doesn't go under your tongue, but it goes inside your cheek, and that's called Belbuca. Again, these are for pain and not for addiction. So does buprenorphine work? The answer is yes. This is a real-life study in a buprenorphine outpatient program, and what it shows is at 24 months, 2 years, 40% of the patients are still in the clinic. And you would say, well, 40%, that's terrible. In medicine, 40% is great, okay? I used to be an oncologist, and we would consider a drug to be a dramatic success if it worked 15% better than another drug or a control group. So 40% is nothing to laugh at. And of those 40% that were still in the buprenorphine clinic, 90% were negative for opioids, 95% negative for cocaine, and about 85% were very satisfied. So again, the success rate for medication for addiction is somewhere around 40 to 60%. And I'll tell you later what happens when you stop taking buprenorphine. So one thing I didn't mention was God's right-hand man, which is the Cochrane Database. You probably may have read of it. And these folks sit around and they examine available evidence on medications, treatments, whatever, and they're not so much concerned about the outcome as they are about the quality of the study. And the problem is that when you deal with medications like this, ethics get in the way of, having a control group and withholding treatment from some patients. But what they said was, buprenorphine is effective, methadone works better at high dose and suppresses heroin use, but methadone is more deadly. So it's a trade-off. Methadone, if you talk to someone who's been on both, people will tell you methadone makes you feel pretty good, Buprenorphine makes you feel normal. Okay, so people often prefer methadone, even though they have to go to a clinic, but on the other hand, buprenorphine is much safer because it doesn't cause respiratory depression. All right, I'm also an OBGYN, so I always throw this in. What if you are opioid dependent and you're pregnant? And what the government said is that this is called a treatment improvement protocol from the Substance Abuse Mental Health Service Administration. This is probably going to get shut down too. But what they said is that the standard of care of treatment in the U.S. is methadone if you're pregnant. Only if you refuse methadone or you can't get to a methadone clinic should you be offered buprenorphine. And they recommend, since the other formulations have 2 drugs in them, the government recommended just Subutex, the single generic. For example, there are no current methadone clinics in the Upper Peninsula. There are really no methadone clinics. There's one methadone clinic, I think, in Petoskey. Otherwise, the upper part of Michigan is pretty much barren as well. So we found in the early 2000s that moms who were put on buprenorphine did well. Babies did well. And I actually delivered the first buprenorphine baby in Michigan in 2004. And we got more and more reports about how moms were doing better on buprenorphine than we would expect. So we finally got a treatment program together and we did a huge study. And this was exactly what you want. It was double-blinded, experimental. There was no control group, but we compared buprenorphine to methadone if you were pregnant and addicted to opioids. And there were 6 or 7 locations over North America and Europe. One of them was Detroit, and Dr. Susan Stein was the principal investigator, and I was the OB for the study. And I'm just going to show you the results very, very quickly, and these are very, very dramatic. These are the babies who were exposed to methadone. These are the babies who were exposed to buprenorphine. And if you look at the outcomes, if someone needed treatment, if the baby needed treatment for withdrawal, the amount of morphine needed was 10 times higher in the methadone baby. The number of days spent was almost twice. The duration of withdrawal, NAS stands for neonatal abstinence syndrome, and that's the baby going in withdrawal, which is really a horrible thing to see. So they give the baby morphine to treat it and get it through withdrawal. It's twice. The birth weight is higher in the buprenorphine babies. The preterm delivery is lower. The drug screens are better. So all of this screams use buprenorphine during pregnancy. And then you get to the last one. 1 out of 3 buprenorphine moms dropped out. Only 1 out of 5 methadone moms dropped out. And I was part of the study. I took care of these patients, and I can tell you there's 2 reasons. People like methadone better if they want to get a high. And also, we were taking moms who are on huge doses of methadone and trying to put them on buprenorphine. You cannot do it. You just can't. And that was a lot of our dropouts. So this study showed that buprenorphine was better for the moms and better for the babies. However, because it was so dramatic, we knew that one group of babies was doing better. We knew which one it was, but we weren't allowed to look at it. It was so dramatic that the ethics board says, you got to stop the study. The babies are doing too much better in one group. So we stopped the study, looked at the results. It came up showing buprenorphine was the better one. And then the FDA said, great job. Oh, by the way, since you stopped the study early, we're not going to approve buprenorphine for pregnancy. This is true. I was part of this. So they're going to change the wording eventually, but right now, neither one of these are approved for pregnancy, and buprenorphine is now acceptable for use in pregnancy. And this, I have a clinic downtown that I see patients who are addicted, and we have them on buprenorphine, and they do quite well. Okay, so that's the 2 agonists, methadone and buprenorphine. Now let's talk about the antagonist. There's only one that is approved, and that is Naltrexone, and it comes in the form of a pill and a shot. And they started off using the pill, and if we gave you the pill every day and then you used, you wouldn't get high. So one thing you will learn about addiction, it is cunning, baffling, powerful, as they say. And what are you going to do if you're taking this pill and you decide you want to use? You're going to stop taking the pill, okay? And if someone says, no, I want to watch you take the pill, you're going to do what one of my patients did and paint it with nail polish, so it goes through your entire GI tract without being absorbed, and no one is the wiser, okay? So the injection turns out to be the one that works. This study was done in Russia, If you are a drug addict in Russia, you have a horrible prognosis. This is a drug treatment center in Russia. And what they do is they bring you in and they handcuff you to a cot and let you go into withdrawal. And withdrawal will consist of nausea, vomiting, and diarrhea, which is why the guy in the bottom is looking so nervous right now, okay? And when they offered this, they had no shortage of applicants because this was the alternative to not sign up with the study. So they had a large number of a pool of subjects. And this is the study in a nutshell. This is 6 months. This is percent of patients who did not use opiates, and this is the placebo group, and this is the shot, the group that got the real shot, and these are separate lines. So Vivitrol is effective in treating opioid dependence up to as far as the study was taken, which is 6 months, okay? And I'll come back and I'll talk about the placebo group in a second. Now, why is this guy handcuffed, okay? He's handcuffed because he craves opiates. Craving is what leads to relapse. You stop using and that's all you can think of. If you talk to someone at a 12-step meeting who gets their 1-year coin for alcohol or drugs, and you say, what'd you think about for the last year? They will tell you alcohol and drugs. It's all they think about. And craving is probably the biggest problem we face. And what they found was, and this doesn't make sense, people who were on the placebo shot continued to have high levels of craving. But people who got the real Vivitrol shot, their craving scores went down. And we don't really understand it. I don't believe the explanation. But for some reason, folks who got this shot had less craving. It was cut in half. And that will lead to less drug use, which is great. And people who were on the placebo shot stayed in treatment pretty well, about 40% at 6 months. People who were on Vivitrol did better. So more people stayed in treatment if they were on the Vivitrol shot. And it's probably easy to figure out which group you're in, so it's hard to double blind it because if you can get high, you're on the placebo. If you can't get high, you're on Vivitrol. Now, what about this? This is the success rate of these folks before they went into this study. Nobody stays clean in Russia, okay? They get unhandcuffed, they go out, they use things like crocodile, which is codeine in industrial solvents. It dissolves your face when you inject it, all kinds of horrible things. But look at this, at 6 months, 40% of the placebo group was still in recovery. And that's the benefit of either placebo or the drug treatment program that was attached, the counseling, the housing, the transportation, and the health. That's the recovery stuff we were talking about. Okay, now, I've been doing this since 2002. I have not yet had a patient not ask me this question on the day they started treatment. When can I get off this stuff, okay? And when I was put on my blood pressure medication, I didn't say, when can I get off this? Because the answer would have been, when you want to have a stroke, fool, okay? But everybody who goes on to medication-assisted therapy wants off it immediately, and they can't wait, and that's a problem. So let's look at how successful that is. So this is a study by Dr. Ludi out of England. She believes that methadone is the work of the devil, and methadone for pregnant patients is just unspeakable. So you can't do it. So she recruited 101 opiate-using pregnant patients, and she detoxed them. And she managed to detox 40 of them, which is pretty good. We'll come back to that. Nobody miscarried, which is something that we're always concerned about. But what they did was they said, okay, you're successful, you've detoxed, I'll see you at delivery. One patient had a negative drug screen at delivery. The others had all been lost to follow-up or were using. And that's the natural history of untreated addiction, relapse, okay? Not a real success story, even though this study is touted as a success story. This is the best known failure study in addiction medicine. This is Dr. Keiko in Sweden. They took 40 actively using heroin addicts and they detoxed them all on buprenorphine. They used the combination product, and half of them were allowed to do what all my patients want to do, which is go on their way. Thanks for the detox. See you around. I'm out of here. Half stayed on buprenorphine and kept getting counseling, and a year later they went back to see the outcome. Here are the folks that stayed on buprenorphine. 75% had negative drug screens and no one died. Here are the folks that tapered off. Nobody had a negative drug screen, and 20% were dead after 1 year. Detox by itself and coming off of medication doesn't work. The medication only works as long as you take it. Now, this is a horrible study to go over, but just bear with me. This is the biggest study ever done for buprenorphine with prescription pill addicts in the world. And this was done on the East Coast. And what they did was they recruited 650 prescription pill addicts. A lot of them had chronic pain, low back pain, which is why my patient can't come off their NOCO, because they have back pain. And they put them all on buprenorphine for 2 weeks and then tapered them off over like 12 weeks and followed up. That's what your patient wants to do. They want to get off this stuff, okay? Here's what happened. It was effective for 50% of the patients. Remember that 50% number keeps coming up. However, over 90% relapsed when they tapered off. Complete failure. So you can give it, it works for half the patients, and 50% in any medical treatment, believe me, that's a success story. But when you stop giving it, it stops working. And this bothers a lot of people. So they said, oops, on to phase 2. There were 360 patients left. Now they put them on buprenorphine for 3 months and tapered them again. Again, it worked for about half the patients that went back on it, but when they came off, over 90% relapsed again, twice, okay? So the moral of the story is that buprenorphine works half the time. These were included our chronic back pain patients that couldn't come off their Norco. They could, but after 2 attempts, the relapse rate was over 90%. Same story. So for medication-assisted treatment, it is effective between 40 to 60% of the time. You're talking about methadone and buprenorphine. If you stop it, once you stop it, you are now at increased risk of overdose. I didn't talk about the mechanism, but the problem is that if you leave the methadone clinic, we taper you out, which means at the end of the treatment, or we taper you off buprenorphine, at the end of the treatment, you are now off buprenorphine, you're off methadone, and you're very sensitive to the opioid you used to go out and use. So you go out, you buy your 4 packs, which is what you did before you went in the clinic, and it kills you. So you're more sensitive to the medication you used to be on. Methadone is better at treatment retention. Buprenorphine is better at safety. And Vivitrol works to improve drug treatment effectiveness, and we don't have enough information to talk about long-term effects when you come off it. Now, this is something that I got this off Facebook. A lot of you have probably seen it. This is our new Secretary of Health and Human Services, and he has made one pronouncement about the future of addiction treatment in the U.S., and he has said that medication-assisted therapy is just changing or just switching from one opioid to another. It doesn't work, and he wants to utilize faith-based programs. Okay? Now, the real problem is the choice of the words. When you say faith-based program, that implies a religious program. And I'm sure a lot of the internet critics all over the U.S. are finally coming to late in the day and getting on their computers and writing all these nasty things about separation of church and state and bringing God back into addiction treatment and how evil this is. But when you talk about faith-based treatment, what you're referring to is spirituality. And spirituality really means just that you have a belief or take direction from somebody outside yourself. And one of the best examples I can think of spirituality is the U.S. Marine Corps, okay? And if you think that they are wimps, I would advise, you can walk up to one of them and tell them about their shortcomings, but I would probably leave quickly thereafter. And you can think about other examples of spirituality. And spirituality can even be belonging to a gang, belonging to a school, anything. But it's believing that, and again, the word belief is there, that what the group or the program does is going to make you better. And that's really what a faith-based program is. It doesn't have anything to do with religion or God. So, what about switching over to talking about programs that don't use medication, abstinence-based programs? These programs can either be a 12-step residential program like Don Farm. It can be based on cognitive behavioral therapy, like a lot of the programs out on the West Coast. But the feature is that after a brief detox, you're not going to be on methadone, buprenorphine. Some patients are still going to be on Vivitrol. And we know that the previous administration, we had the drug czar come talk at U of M last year. He and I were on a panel. He was strongly in favor of medication-assisted therapy, and there is no drug czar anymore, and the National Office of Drug Control Policy has been dissolved. If you go to the website, it's been shut down. So it's kind of obvious that things are going to have a dramatic change. People who advocate abstinence-based programs are often accused of religiosity, cultism, being goons for AA, this is a government conspiracy, et cetera, and there's a lot of vitriol out there. Unfortunately, I have to read through it every year when I do this talk, but if you just look at it, you put in AA as a cult or whatever, you're going to see no shortage of articles. And the accusation is that these abstinence-based programs are no better than what we call spontaneous remission, meaning that a lot of people will stop using on their own, and a few really hardcore addicts will keep going on. So there's really no point in an abstinence-based program. So is there anything to support this, yes or no? And the answer is yes. These are what we refer to as the safety-sensitive professions. This is defined as someone who has been entrusted by the public to take care of us, and we expect them to be held to a higher standard, which means that you might want to go out and mow your lawn this weekend after a few beers, but we don't want these guys drinking a few beers before they get on the plane. And it happens a lot, by the way. So we hold these folks to a higher standard: law enforcement, healthcare, judges and lawyers, and airline pilots. And we get it. I'll show you how. Here's also another safety-sensitive profession, either a pregnant mom or someone who has a newborn. And I work with these folks, and they do very well during their pregnancy when they're being monitored and treated. However, after they delivered the baby, I'm going to show you how when the treatment stops and the monitoring stops, things can go really, really wrong. So for healthcare professionals, for doctors, these are known as physician health programs. And the one in Michigan is called the HPRP. I'm the medical director, and we monitor about 800 doctors, nurses, and pharmacists who have been diagnosed with either an alcohol problem or a drug problem. And these folks are all evaluated, they're sent to treatment, they go to either 12-step meetings or what's called smart recovery, which is non-AA mutual help meetings. They're monitored, they're watched for 3 to 5 years, and most of our programs don't allow medication-assisted therapy, which I don't think makes any difference, but the reason they work is that we watch them carefully and we respond immediately. Our success rate is between 80 and 90% compared to all the other programs we've been talking about. And of the people who have a positive drug screen, most 15% out of that group left over only have one positive drug screen and go on and do well. It's an incredibly successful program, okay? And this is just a study that looked comparing buprenorphine treatment to physician monitoring programs. And the idea here is that we know that 50% of the patients or more on medication-assisted therapy are going to relapse. The relapse rate in our program is low, and the percentage of positive drug screens is also very low. It just shows that these programs work. Now, let me give you a little jaded interpretation of why these programs work. They work because doctors have more to lose. I hear that all the time. I work with pregnant moms who are trying to keep custody of their babies and trying to keep custody of the kids they have and the kids they are going to have. Is there anybody who has more to lose than them? No. This is nonsense. I'll use a polite term. They work because doctors are smarter. I've been teaching medical school since 1990. Next statement. They work because doctors can afford treatment. That's true if you get to a doctor or a nurse or a pharmacist before they've crashed and burned and are homeless, jobless. But we have healthcare professionals who are in the Salvation Army and who are enrolled successfully in our program. They're essentially homeless. They work because doctors get special treatment. That one's true. We expect more from safety-sensitive professions. We monitor them, and we get the results. Do you have to be a doctor or a pharmacist to get this program? Nope, you can be another kind of criminal. This is called the Hawaii Opportunity for Probation Enforcement, the HOPE program. It is usually pretty much methamphetamine addicts in Hawaii. And methamphetamine addicts have a very severe, virulent version of addiction. It's very, very very, very poor prognosis in most cases. This is the failure rate in those folks on probation with regular treatment. Arrests, drug screens, skipped appointments, and violated probation. And this is when they use the HOPE program, which, by the way, is almost identical to our doctor's program. That's failure rates, which means the success rates are 90 to 80%, the same as the doctor's program. You can apply this to anybody, and it works, okay? Here's one in the state of Washington. It's called Swift and Certain, meaning when something happens, they act, they take you off work, they send you back for an evaluation, and you may go back to treatment. Okay, what happens when you stop monitoring? Is everything okay? And the answer is usually not. This is the reasons that moms died in Colorado, and I think they looked at 211 moms who died, and they looked at when they died. About 12% died while they were pregnant and being monitored. 2/3 died after they delivered. Why? Because the heat was off, Child Protective Services went home, nobody was watching, they were free to relapse and start using again, and they died. So monitoring not only protects the public, it protects the patient. Now, not everybody is enamored with this. There are some folks who say that medical directors like me are serial killers. That was the expression this doctor used. So if you want some amusement, go on the internet and look up the disrupted physician. This is Dr. Michael Langan. He's a doc from Massachusetts who reported himself for opiate addiction to the Massachusetts Medical Board, and he did not like how he was treated. So he has launched a blog, and I think most of the ravings and rantings you'll see are pretty obvious, but it's amusing if nothing else. Okay, so we're going to move on to talking about opioid rescue or opioid overdose rescue, and this was developed for Families Against Narcotics, and I'd like to bring in one blurb. We have a new chapter in Western Wayne County. We meet in Canton on the first Monday of every month at 6:30, and if you go online, you can find our website, and we're going to meet every month and have different topics at each meeting. So the two drugs we're talking about here are Naltrexone, which we're going to stop talking about, and Naloxone. Naloxone is Narcan, which is what we use to rescue people. Naltrexone is for treatment. Naloxone is for rescue. If someone is overdosed, their death will be from respiratory depression, and Narcan can reverse it. It only lasts for minutes, and it acts very quickly. It's available IV, by shot, by nasal spray, and we'll talk about the different formulations you can get. So Narcan is not a miracle cure. Narcan does not treat an overdose from benzos or alcohol or a mixture of opiates, benzos, and alcohol, which is very common. But it can reverse the opioid part of the drug overdose and often keep the patient alive until someone can get there, and we're going to show you a video when we're done, and those of you who wish will get a prescription that you can fill if you have a family member who is at risk, or for yourself, and if it's for yourself, it should be covered by insurance. So this is the different brands of Narcan. The standard dose of Narcan is 0.4 milligrams, and it comes in a shot, it comes in a nose spray, and it also comes in what's called the SVO injector. I didn't bring one with me, but when you pull the cap off, it talks to you. It tells you to stick it in someone's leg, count to 5, and then pull it out. So if you have a family member who's not familiar with what to do, it actually talks them through it. And for $800, it should do a lot for you. And this is our therapy dog, Olive. Now, this is the new formulation. Because of fentanyl, more people are dying from overdoses, and overdoses are harder to reverse. Those ones I just showed you were 0.4 milligrams. This is 4 milligrams. It also comes in a week or 2 milligram. And it's a one-shot deal. We'll show you how to use it. but you put it up to someone's nose, push the plunger, and then afterwards you do rescue breathing. We'll come back to that. So who overdoses? People who are regular users, as long as they don't get one of those horrible, carfentanil drugs, which, can't be tolerated by anybody. People who are regular users will not overdose unless they mix it with something else or they get one of the new analogs like fentanyl or carfentanil. But people who have been clean for 2 weeks, either in treatment or jail or have just relapsed, people who are coming off their medications are now sensitive, people who mix opiates with alcohol or benzos, and then here's the big killer, fentanyl. In my methadone program downtown, 50% of the patients who are positive for heroin are also positive for fentanyl. It's a crapshoot. You're going to get you're going to get fentanyl 50% of the time. When we first found this out, which was like a year and a half ago, everybody went crazy. We, started talking to patients, you got to stop, you're going to die. And when I would tell them that the heroin you're using has fentanyl in it, their eyes would light up. Okay, it was the wrong thing to say. So, I was telling them that their lives were in danger, and what they felt was they were getting an extra bang for their buck. So no one stopped because we counseled them. Here is a drug screen from a pregnant patient that came to our clinic. These 3 drugs up here are from heroin, and these 2 down here are from fentanyl, and here's marijuana up here. Again, 50% of our samples that have heroin have fentanyl. So how do you do a naloxone rescue? You want to make sure someone's not breathing, and we're going to show you a video at the end if you want. And you want to wake them up if you can. You can do it by doing something painful. You can squeeze their earlobe, you can push on their upper lip, you can mash on their breastbone, and if someone wakes up, then they're okay. If they wake up and they go back out, then you got a problem. If they don't wake up, you got a problem. This is the most dangerous thing you're going to forget. You're going to forget to call 911. And you're going to be there and the Narcan's wearing off and you got to do rescue breathing. You're thinking, where's the ambulance? And then you realize you never called for one. So I tell people to call 911 before they do the rescue. Even though it's a few extra seconds, it means you won't forget to call them once the rescue started. Do rescue breaths, and we're going to show in the video. Give them naloxone, go back to rescue breaths. If you have an extra dose of naloxone, you can give it 3 minutes later. And if you don't see the video tonight, but you want to review it later, if you go on YouTube and put in my email address, ccmdphd, there's a channel, and you'll see a bunch of Narcan videos. You'll also see my grandkids and my dogs and my wife, but you'll also see the Narcan videos. So rescue breathing, we'll show you, just means you got somebody flat in their back. You tilt the head back so that their windpipe is straight. You pinch their nose if you don't have a mask. You breathe into their mouth. Now the problem is, you've probably heard in the news over the past few days, there have been overdoses from doing this. There was a police officer in Wayne County who overdosed by brushing white powder off his shirt. He had to be taken to the hospital. So these are drugs that have fentanyl or carfentanil in them, and they can be lethal. So I imagine that a lot of people are going to be choosing not to put their mouth on someone and do it in rescue breaths. You do 2 breaths, 1 second each. You want to see their chest move, not their stomach. If their stomach moves, that means you're blowing air in their stomach. So tilt their head back farther and do it again. This is the comparison between the shot and the nasal spray. This was done in New Zealand, and all it shows is they both work. Don't worry about it. Don't pick one over the other. Whatever you can get is what you want to use. And after EMS gets there, be careful of needles. If you've used needles, be careful that they don't have a needle or a syringe under them. Clean up all the blood because it may be infected with hepatitis or HIV. And hopefully when they go to the hospital, we are working now to get programs where we have volunteers or paid professionals who will go to the hospital, meet somebody who is overdosed, and try and talk them into getting into treatment. Okay, so last topic is going to be alcohol. This is Leaving Las Vegas with Nicolas Cage. If you have any questions about end-stage alcoholism, I suggest you watch the movie. It's pretty accurate. And the treatment for alcohol dependence is more varied, and more successful in many cases than it is for opioids. Opioids are just harder to treat. So the treatment for alcohol dependence can be AA, or if you hate AA, there's other programs. The one that is the most legitimate is Smart Recovery, and the ones that are not legitimate are Rational Recovery. If you go on their website and read it, they say we can cure you in one treatment and buy our book. Okay, so I'd urge you to be careful. There's also something called cognitive behavioral therapy, where you try and find out what's the underlying beliefs you have about yourself that are leading to this kind of destructive behavior. Motivational enhancement therapy, which means you talk to somebody and you say, on a scale from 1 to 10, how ready are you to stop shooting heroin? And you can tell from my approach that I was never very good at it. My wife and I attended a M.AT course a few years ago, and they pretty much recommended that I not come back. So, and then you have medications, which is what we're going to talk about next. So, the Cochrane Database, the Bible says that there is no unequivocal evidence that says that AA works better than anything else. Now, when you read on the internet, when they take this phrase out, they take this one out and they say, there is no unequivocal evidence that AA works, and they just leave this part out. So they can say that AA, they can show that AA doesn't work. But it's true, because of the ethics involved, even the biggest study that was done called Project Match did not have a control group that wasn't treated. It wasn't felt to be ethical, so that compromised the study. So this is an article that if you send your email address to me, I'll send you this article. This is Dr. Leanne Kudis. She's from the West Coast. She announces when she gives this talk that she is an atheist, but she believes that AA is the most effective form of treatment, and let me show you some of the research that backs that up. This is a study done, I think, in the male VA patients in Los Angeles. These are patients who went to AA at 12 months and 18 months, and these are patients who didn't go to AA at 18 months, and this should be 12 months, okay? And the abstinence rate is twice as high, or more than twice as high, for the patients who went to AA. Now, the argument against that is they weren't randomized. Maybe these folks just wanted to get sober and they went to AA to kill time, okay? I don't really have an answer for that, but I think it's pretty clear-cut that going to AA is associated with a higher abstinence rate. This is how many meetings you go to. You may have heard the expression 90 meetings in 90 days, okay? This is the abstinence rate, anywhere from 0 to 70%. This is going to no meetings in 90 days, 1 to 20, 20 to 50, and more than 50. And this is a straight line. The more meetings attended, the higher the abstinence rate. Again, you can argue that because this wasn't randomized, it's not valid. I'll leave it up to you. And this is how often people go to meetings, and this is in the up to going to 2 years in recovery, and these are folks who never go to a meeting, go to a meeting less than one per week, or go to a weekly meeting at least. So it's pretty clear-cut that there's a higher rate of abstinence. Again, you can't prove that AA is the cause. And Project Match, if you just Google this in Wikipedia, it talks about it. Project Match to people coming out of treatment, and they were randomized to cognitive behavioral therapy, motivational enhancement therapy, or what was called 12-step facilitation. And there was no formal control group because everybody knew that AA didn't work, so they assumed that 12-step facilitation was the control group. And the outcome was that AA worked better than the other two. And again, since there was no control group, it's been argued that this is not a valid study, but I actually went to this online collaboration of statisticians. I can't imagine anything more terrifying than being a statistician. But I sent them the data and I said, is this valid? And they went back, they replied, yes, it's valid. It would be better if there's a control group, but this study is valid. And leave us alone. And it turns out they went back and they looked at Project Match 10 years out, and people do better if they remained in AA. 80% of the people who remained in AA were abstinent compared to very few of the people who left AA. The problem was that most people chose to stop going to AA and things did not go well. But this is the 10-year outcome for Project Match. So, okay, how about medications? So, remember dissecting a frog in high school? That horrible smell and the stuff that got on your hands and it burned and your clothes smelled like it and you got in trouble when you went home? That is formaldehyde. And on the way to being burned up, alcohol turns into acetaldehyde, which is very similar. And there's a drug called antabuse, which turns alcohol into acetaldehyde. So think about taking that junk from that frog and injecting it into your blood, how sick you would get. That's what happens when you drink and take antabuse. So the idea is that you learn that you get horribly sick when you drink, so you stop drinking, right? No, you stop taking the antabuse, okay? And that's what happens. So even though this is theoretically very effective, and it may work in a special situation where your family monitors you and you have no nail polish in the house, so you can't paint them with nail polish. Otherwise, this has not been shown to be an effective treatment. And when you drink and take antabuse, this is what happens. So the other one is naltrexone. We just talked about naltrexone, right? And again, it's available in the pill and the shot. And why would you use an opioid blocker for drinking alcohol? The reason is alcohol does two things. It makes you stagger, it makes you get arrested, and the other one is it makes you high, it makes you euphoric, right? You get high off drinking. That pathway in your brain that makes you high from drinking is the opioid pathway. It's the same pathway. So if you block that opioid pathway, then you won't enjoy drinking, but you still get drunk and you can still get arrested. And the oral naltrexone works as long as you're in a research study, but as soon as you take it home, guess what? You stop taking it. So they use the shot. And this is how effective it is over 6 months if you have people who stop drinking and then go on placebo, the low-dose shot, Here is the high-dose shot, and here is the placebo, and in between is the low-dose shot, okay? So all three of these groups quit drinking and then continued to relapse at different rates. But statistically, the Vivitrol shot decreased the amount of drinking, but it did not make a huge effect. And I want you to remember this slide. This is the placebo effect we see when we talk about treating patients with psychiatric medications. Here are the number of days drinking before you entered the study, 25 to 30. So people were drinking almost every day. And then here's what happened when you ended the study and you got the placebo. Your drinking was cut in half just by going into the study. And then by getting low-dose Vivitrol, you got a little more, and high-dose Vivitrol, you got a little more, but the major effect was just being in the study. So that's what you have to, it's a cautionary tale when you look at these research results. The majority of the effect was just signing up. There's a drug called Campro, which is a camprosate. It's kind of a strange drug. And when you read up on it, it says we don't know how it works, but go ahead and take it. So you want to think twice before taking it. I have one patient who's on it and doing well, and otherwise everybody that I've met were patients coming into our detox unit who were taking it, and they were also drinking. And then this is the biggest study ever done on this combination of medications. So they took behavioral therapy, placebo, naltrexone, Campro, mixed them up together, split alcoholic patients in different groups, and saw what the outcome was. It's a horrible paper to read. I will not read it more than once a year because I get a migraine every time I go through it. But here was the outcome. The people who did best were just taking a pill, either a placebo pill or a medication pill, in this case naltrexone, but not the Campro. That was more important than anything else, the groups that took pills, and nothing else mattered. And that's kind of a sad state of affairs. They couldn't make any benefit from behavioral therapy or anything else on its own. This is Dr. Sinclair, who's passed away recently, but he wrote a technique for stopping drinking called the Sinclair method, and this is very popular in Europe, and I am the only doctor I know of in Michigan who prescribes it this way. There's one doctor in Windsor who has a lot of patients. But the way you do this is you don't take naltrexone every day. You just take it on the days you're going to drink, and you don't enjoy the drinking. So eventually you get bored and say, why get a headache if I don't get high? And his research showed about a 75% success rate, and the people I've put on it have drank less, but I don't have anybody who has quit drinking completely. And because a lot of the people I meet, have a pretty bad alcohol problem, very often we recommend they quit drinking completely. Baclofen is something you may have heard of. This is what we use for people who have a damaged spinal cord and they have really bad spastic muscles. It calms them down. If you give them enough baclofen, they quit drinking, but then when you try and take them off the baclofen, they may have a seizure. It's a risky drug to taper somebody off of. It's not approved by the FDA. There's a research protocol that got started and never finished that I'm aware of. Okay, so remember what I told you at the beginning? He's very depressing and I left entirely without hope, okay? So this is the situation we have right now with treating addiction. Addiction can be treated. It can be successful 50% of the time, other than that special populations group. And when you stop the treatment, people relapse, okay? So when you hear enough of this, you think, why bother? And this is a paper written by Tom McClellan, who for a brief time was the drug czar of the U.S. Again, there is no more drug czar in the U.S. But he wrote a paper comparing addiction to other chronic illnesses. And he said his number published was 40% of patients succeed at addiction treatment. I've been talking to you about 40 to 60% all night. And he said the 60% who fail, there's a lot of reasons, and they may or may not be fixable. You're not going to fix low economic status. Patients have psych problems. And people say, well, if 60% are going to fail, why bother? That's hopeless. And then he turned around and he said, oh, really, what is the benefit or what is the success rate of diabetics? 60%. Asthmatics, 40%. Hypertensives, 40%. Drug dependents, 40%. It's all the same. These are illnesses that we consider chronic and incurable, meaning if you stop the treatment, they come back. But we have the same success rate as other chronic illnesses. The difference is that, the patient who's diabetic, if they stop taking their insulin, they don't go out and steal the tires off your car, which is something that happens very regularly at our downtown clinic. So if you were a diabetic and stopped taking your insulin because you just got fed up with everything, you would go into a diabetic coma. I would come to see you in the ICU and say, listen, you idiot, you almost died. Here's your insulin prescription. I'll see you next week. But if you have addiction and you stop your buprenorphine, your methadone, your 12 steps, your naltrexone, whatever, and you relapse and wind up in the ICU, I'm going to come see you and say, you're an addict, you're hopeless, you're fired. We do this because we get frustrated. We do this because an active addict is not a pleasant person to be around. Everybody has done it. I've done it. We shouldn't do it, but it happens. And we need to try and realize that we're just dealing with a chronic relapsing disease like diabetes. So addiction should be added to this list here. Now, my blurb, I've already given it to you. We have Families Against Narcotics. It's a fantastic organization. We have a new chapter in Western Wayne County in Canton. And again, you can find it on the internet. I'm a member of the advisory board, and we'll be meeting on the first Monday in June. And if you want to learn about addiction, if you've got a family member with addiction, especially if you have a family member with addiction, you'll get a lot of help there. And this is our non-narcotic therapy. This is my wife, Kathy. She and I have a private practice in Ann Arbor. Wave, Kathy. And this is our dog, Olive, who's our therapy dog. She monitors the waiting room. If you come to meet us, you will meet Olive, and you will pet Olive if you want to get out of the waiting room. And here's my contact information. And I'd be glad to take any questions right now. And then what we're going to do is we'll split up, and those who are interested, I'm going to ask you to watch a short video about rescue breathing and giving nasal Narcan, and then I can give you the forms that you would need to get a prescription.